Today, our first speaker is Grzegorz Lewicki. He graduated optometry at the University of Warsaw and in Poznan. He conducts professional eye examination and vision therapies in adults, adolescents, and children. He is a vision therapist and a dispensing optician. Grzegorz is the only Polish optometrist who obtained an international clinical fellowship of the College of Optometrists in Vision Development in the United States. And today we will hear a presentation called Optometry and the Vision Therapy in Autism. Grzegorz, please. Thank you.
Thank you very much for your introduction. I will not say anything more about me. I'll just go to the presentation. First, I'd like to say thank you
Želim da se zahvalim
the organizers of this conference because of your effort, this conference may happen, and I know there's many parents in you, and you, because you want to help your children, you organize this conference. So this is something to be. I like this spirit of helping the children. This is something that should be followed. So vision is an important piece in the puzzle of autism. And I like these pictures of puzzles because there are a variety of things that we need to consider while treating autism spectrum disorder patients. And vision is one of that. So if we think about the autism, there are some major brain structures that are implicated by autism. The cerebral cortex, which is responsible for higher mental functions, the amygdala, which is responsible for emotions, the hippocampus, which is responsible for memory, and also some more ancient structures like cerebellum, which controls movements, and brainstem, which serves for heart beating and breathing. And I'm saying this because when we think about vision is everywhere in the brain. It's of course it's occipital cortex, that's the primary visual cortex, but also it's a parietal cortex where we have a spatial vision and localization. We have also temporal vision when we have an visual identification and memory. It's also frontal cortex when their eye movements are guided, when there are motor planning, when there is eye-hand coordination. Also, the limbic system, which is responsible for circadian rhythms, which make us awake and sleep. And also the other extrapyramidal pathway, which control the automatic movements and, of course, cerebellum as well. So, because autism implicates the brain, and vision is the brain, vision will be affected as well. And because vision is the brain, by visual input, we can change the functioning of the brain. So now I'd like to ask the audience, how many parents are here? Can you raise your hands? Thank you. And how many doctors are here? Thank you. And how many optometrists are here? No one. So I just want to adjust the way I speak to the audience. So there are some explanations that must be done to go forward in explaining how vision therapy may help in autism. And the first one is the difference between the eyesight and vision. The eyesight is the only ability to see clearly at certain distance, the certain letters. And the vision is ability to see, is the ability to understand what you see and interact with the world around us. So what do we need to interact with the world? There are some specific visual abilities that are needed. And acuity, which is the sharpness of vision, is only the one of them. But what about the focusing ability? So this is like in the camera when we switch the focus at the certain distances. What about the teaming, how the eyes work together? What about tracking and eye movement control? So how the eyes are guided by the brain? What about alignment? Are the eyes aligned or they're crossed? Maybe some strabismus. What about the peripheral vision? We don't only have this sharp central vision, but we also have the periphery. When I look at you, I have something in my peripheral vision, which serves as the coordination of vision. What about visual perception, the meaning that is given by the brain to what we see? What about color perception? So as you see, there are so many skills that are needed to interact, to not only to see clearly, but to interact with the world. And most of visual screenings do not look for these visual skills. So again, visual acuity is only the measure of sharpness of sight. It doesn't tell us how meaning is obtained from what we see. Also, it doesn't tell us how much effort is being done to see clearly. For example, we can have a child who is +6 of farsightedness, and he is able to, or she is able to see clearly, but with much effort. The eye movement control. Here we have a child who has eye movement disorder. The task is to move from one ball to the other with only the eyes. And you can see he moves his head, he moves his whole body. He's not able to change the gaze from one ball to the other. And this is essential for example, ball tracking, for tracking while reading. When we read, we change the gaze from one word to the other and from one line to the other. And when it's impaired, we cannot do it efficiently. Also from book to chalkboard, but we use eye movement all the time. The focusing ability, which is ability to change the focus from distance to near, from other distances, and to maintain the focus. And it's not only to change, but also to maintain the focus. And this is crucial for visual attention. When the child is not able to maintain the focus, she or he will lose attention. And binocularity, we have a brain because to have the eyes aligned, there should be proper brain functioning. It's not the muscle problem, it's the brain problem. So do we have efficient coordination of both eyes? if we can efficiently coordinate our eyes, we have corrected eye error, and the visual information is passed to the brain, then how the brain interprets what is being passed to him. So visual perception is the giving meaning to what we see. It's the discrimination, interpretation, and memory what we see. And it's critical for all areas of performance. So visual symptoms in autism spectrum disorder population are linked with underlying differences in central nervous system, which includes visual system. This is something what we said before. So briefly, what visual treatment may have impact, may benefit for this population. But first, we need to know who is going to treat them. And the only specialist who can treat them visually is behavioral optometrists. Because behavioral optometrist doesn't work only with vision acuity. It works with vision when the person is seen as a whole. He uses special lenses, not the compensatory lenses for refractive error, but special lenses that influence vision in the brain, vision therapy. So our job is to make the patient to full visual potential. At the end of the presentation, I will show you some links where you can find more information about behavioral optometry, but because not every optometry will help. So we use, of course, compensatory lenses for nearsightedness, farsightedness, because sometimes it's needed. Optometric vision therapy, optometric phototherapy, some filters, special occlusions, and special neurobalancing lenses which influence the brain. So again, compensatory lenses just are designed for compensate for nearsightedness, farsightedness, astigmatism, and they are needed because of high incidence of refractive errors in ASD population. It's much higher than in the general population. But what we see is the refusal of wearing glasses. We need to bear in mind that sometimes we will not be able to cooperate with the child. Here we have some examples of vision therapy. Vision therapy is the very big subject that we don't have time to cover, but just to give the idea how it may look like. So the first one is the eye-hand coordination and eye movement therapy. The last one is the tracking eye movement control and smooth eye movement therapy, and also the patterns, because the task is to put those beads into a specific pattern of square and triangles. And in the middle we have the vision perception therapy, when the shapes should be arranged in the specific pattern. So the visual perception therapy. Of course, these are only examples. Here we have a nice boy from Ukraine that we treat in our clinic in Warsaw. Behavioral optometrists use also syntonics, which is optometric phototherapy. Personally, I don't use it yet. I'm in training to use syntonics, but there are many optometrists who use it in the day-to-day basis. Basically, it's the therapy that we use some light frequencies to stimulate the brain in a specific way. So, for example, there are frequencies that may make the child calm or more awake. There are some frequencies that may be used for inflammation. They are used for strabismus when we have the eye squint. And there are some reports from some of optometrists that they help for autism spectrum individuals. For autistic patients, very important are neurobalancing lenses. And neurobalancing lenses are not designed to compensate for vision acuity. Their task is to influence the brain so that the child has more connection to the world around him. So it's helped to integrate the internal and external world. And the examples are yoke prisms, developmental lenses, which are designed for proper vision development, microprisms, and the other. We have a research section at the end, but here I put some research about the yoke prism and Ulti spectrum. Yoke prisms are the prisms that are in the same direction, and there are some research that they improve the orientation, posture, and reaction and engagement to visual task in autistic individuals. And as you can see, the research is from 20th century. There are some more recent, so it's being done for years now. And here we have Tatiana's daughter, so thank you for letting us to show it. So here is autistic child who presents toe walking. We'll see it in a second. So basically, Tatiana, in her heroic effort to help her daughter, went to Spain to Dr. Pilar Vergara and Dr. Bob Sanet to seek for help visually. And they were looking for some neurobalancing lenses that may change this pattern of toe walking. So after some times of examination, they found lenses that wipe out this toe walking. As we were discussing yesterday, it goes like this. If we find the specific one, there's no toe walking. If we take them off, there's still toe walking. When we put them on, we don't have toe walking. Of course, in autistic individuals, we have the gaze aversions. So to change it, we can use yoked prisms, the one we mentioned just before. We also use binasal occlusion. This is the sectoral occlusion that may be taped into the glasses, that is hardly seen by the patient, but it removes the visual noise. And also behavioral optometric vision therapy and phototherapy integrates the vision with other senses and may be helpful with gaze aversion. So, in general, behavioral optometry is a crucial part of the team of treating the people with autism spectrum. I hope that I convinced you about this. For more information, you can go to COVD website. COVD is the international association where you can find behavioral optometrists and of course more information about vision and autism. There is a more closer association in Europe. It's CIODEC, it's in Spain. You can also go to my website. You can find the contact to me, and you can write me an email. If I can help, certainly I will do. And we have the research part, but at this point I would like to thank you for your attention, and I encourage you to ask me some questions.
This is an important direction of habilitation of children with ASD. I have a question. In your opinion, how much important cortical visual agnosia in the ASD ed, and how many is it linked with more functional disruption in the visual cortex or physical disruption in visual cortex? Maybe I have experience in evoked potential or functional MRI.
Yeah. Well, it depends on the autistic individual and its profile, because sometimes it's the structural, sometimes it's functional. And we can see it, for example, in strabismus, where before we thought that it's structural, but now we can see that it's in the synapses and neurotransmitters, so it's more functional. So it depends. Recently, I was talking to one of the parent of autistic child, and we were speaking about the visual perception. And I told her, well, we did one examination, we need to do the other one of visual perception. And I explained what is the visual perception, that maybe he has problems with puzzles, and he told me, no, he's better than the others with the puzzles. So I think it depends. That's why it's so complicated to treat those patients, because there are some different individuals, and different changes in the brain may be seen.
Thank you very much.
But yeah, there are some fMRI studies as well. It's in the research section.
Thank you.
Can you tell us about behavioral problems that are, per the research or your experience, associated with some visual problems which you would not usually think is the case?
Yes, of course. For example, the posture. Posture is usually not associated with vision. And to have the proper posture, you need to have coordinated the vision input, the input from ears, and the proprioceptive input. And they are coordinated in the midbrain. So the visual input is very important for the posture. And for example, your quiz may change the visual posture. So this is something that is not linked. If you go, you may go to physiotherapists, but you will not go to optometrists.
But for example, schoolwork, which is here, maybe some children have problems with that because they don't see here, or they don't see the table. Maybe this is also something that is associated, where a refusal of schoolwork.
Yes, of course. And you can see the child that sees everything. That's the problem. She or he may see clearly at distance. She or he may see clearly at near. But so much effort is being done to see, to maintain the focus, to coordinate eyes, to understand what is read, that the child loses attention very quickly. So that's why the visual screenings miss much of these skills.
Okay, we have, I have a question, and then also there is one online. Why do number of children that are ASD children very often look from the side?
Yeah, this is, there are some different etiology proposals for this. One of this is some movement perception disorders. The other one is that the child is overwhelmed with visual information. So for example, if the child would like to listen, he would change his gaze to reduce this visual input. Also, some postural changes may be associated with this. So it's not easy to explain this, and there are some proposals why it's seen.
Okay.
But
it can be corrected. This looking to the side, it can be corrected with the things you do.
Yes. It's not. It doesn't work all the time, but there, as soon as it works, for me, it's not. Although I look for some research, it doesn't. So it's not so important. Why exactly? It's important that it works.
Okay, we have some questions online.
Yeah.
Do you do telemedicine, online consultations and therapies?
Well, I was asked yesterday. The answer is no, but I may consider that. In the pandemic, we were thinking about this, but we were so occupied by the patient when we went back for our clinic that we didn't think about this anymore. But we may think about this. The problem is with this is for telemedicine, you need to, when you do vision therapy, you need to see where eyes are and see where the image are, where the patient perceives the image, and through the camera it's very hard to do it. So you need to have the trained individual. So that's why we were speaking with Tatiana yesterday, that maybe we can do some training for optometrists here in Serbia, and then with their hands we can help patient even through the camera.
Okay, we have, yeah, it's a good suggestion. Okay, so another question. Ocular involvement is a pattern that is repeated in the neurometabolism of children with autism. Do you think that the post-vaccine involvement may be a factor?
Once again, please.
Okay, so the ocular involvement, yes, is a pattern that is repeated in the neurometabolism of children with autism. Mm-hmm. Do you think that has to do something with the post-vaccine involvement?
I'm not aware about this. Okay. I'm sorry.
Okay. And what is the advice for parents whose child has a low visual attention? Can iPad harm them?
iPad can harm them?
iPad
yeah.
Tablets.
Yeah, of course, because patients with autism spectrum are preoccupied with details. They don't see the general picture. And when you look at the iPad, which is right here, you lose everything which is around you. And you may be preoccupied with some very small details in the image that you see. So what we do in vision therapy, in many, not only the autism spectrum, but in other problems, we do central and peripheral integration. And this is disrupted by electronic devices.
Hi, I have a child that's definitely a candidate for vision therapy. I can see that right away. So since we don't have that here, if we would come, for example, to your center and do some exercises, can we then continue to do that at home? Is that possible? Because I see all these equipment that we don't have here, like how would that work? And also with lenses, if he gets lenses, these specific lenses, is that training, like, is that retraining the brain to see better and then you like don't need them after a while, or how does that work?
This is something what we are looking for, yes. For those neurobalancing lenses, at the beginning you need to wear them, but it's not wearing all the time. Wear them, you put them off. It depends on lenses. You may prescribe them, you may do them in the glasses. There are smaller powers then, or you can put them as the glasses for training to do at home. So then you put them on and then you put them off, and at the time you don't need them anymore. So sometimes they are needed for being prescribed for and you need to wear them all the time, but sometimes they are designed for the training, and after sometimes you don't need them anymore. Because they open the visual world. If you connect the child with the world around him, maybe after sometimes the child knows how to connect without those lenses.
And what about vision therapy?
Yeah, the vision therapy, yeah. It depends on the child, because there are so many different disabilities that may be seen visually in autism spectrum. There are very high incidence of strabismus. It's up to 75%, which is comparing to 2% in general population. There are eye movement disorders, so there are high incidence of the refractive error. Sometimes we can do it at home. Sometimes we need someone to guide the child.
So how long would be optimal, for example, if we come and stay for a while for therapy?
It very depends at the case. Because, for example, if we treat strabismus, we treat it in sometimes when it lasts for years, it's up to 2.5 years of therapy.
So we need vision therapy here.
And sometimes it's a matter of months. So it depends. I'm thinking about, because sometimes if you're not trained properly, you may do more harm with those lenses, with those procedures. So that's why sometimes it's hard to do it in the home basis.
Okay, thank you. And there is one more question online. Actually, there's more questions than one, but let's do this one. How do you examine a child who is very, non-verbal, hyperactive? How do you examine them at all?
This is a very good question.
Yeah.
Well, what I want the child to do is to look at me, and it's very hard, because when the child may be able to fixate at me, I may take so many informations from this. I may see if the eyes are aligned. I may see the media opacity. Is the eye healthy? I may see what is the refractive error, what is the eye error. So there's so many things that I can take from just look at me. And in autism spectrum, sometimes they don't look at me anymore. So what I'm doing is I need to know the child first. So basically, I'm not standing like I'm standing here. I'm in the ground. I need to adjust for his level, so he can feel secure looking at me. Then I change this distance from us, but when I see the aversion, I may go back. I will look for the posture and for the behavior. I may ask the parents to put some glasses on and then observe how they change the behavior. So depends on cooperation, but what the advices are not to be like the doctor. And it takes time. Yeah, for me it's 1 hour. I have 1 hour for a visit.
So, ja ću sad prvo na engleskom, pa na srpskom.
Sometimes you can see, sometimes the child cries, and it cries for 10 minutes, and you can think, oh, what, I am such a bad doctor that the child is crying, but it's not my fault. I may hear that he used to cry even before he came to my office, but I need to wait this and to be patient and wait, and then if the child may feel more secure, they will open to this exam more.
So I will say first in English, onda ću na srpskom, because my child went for an exam, so I can explain that it is a playful exam. The child doesn't feel like it is at the doctor's office, because vision can be seen with giving a toy or a book, and they use these kinds of things to see how the child is reacting to visual things. But there is also a lot of questions for the parent, a long list of questions. And I would also like to say that we are establishing a scholarship with the National Society of Optometrists for somebody to get educated as a visual therapist to be working in Serbia, but this will take several years because it is a process. So before we establish that, you can go to see some of the very low number of optometrists in Europe, huge number in America, a low number in Europe, but you can go and see them. So, mislim da ne moram na srpskom, jesmo svi razumeli. Ok, hvala.
It's essential, thank you. It's essential to go to this behavioral optometry, so that's why I put some links, because there are different vision therapies. Orthotics vision therapy usually doesn't work at these problems. So I believe we don't have much time more, but I don't know if you have the template of my presentation. If the participants do have my presentation. Okay, that's great. So you can read this research, the other section. It's more boring than the first one, but you can see that it's not like we are just trying to do something without this research. There's research that is being done for years now that supports vision therapy in autism.
Thank you very much.